Okay. Hi, everybody. Just quickly, we are recording this. So I would like to introduce our first speaker, Beth Clark. Beth has been involved with horses for her whole life and has ridden with some of the best trainers. She is a graduate of the University of Virginia Law School, where she practiced corporate law and served a brief tenure as director of dressage for the United States Equestrian Team before establishing her own law practice. She has taught equine-specific business and law courses at the college level and has published many articles on the business side of horses. Her current law practice is concentrated on individual and small business management services, contracts, estate planning, and alternative dispute resolution. Her clients include some of the country's top dressage riders, sport horse breeding and training farms, veterinary practices, as well as other busy individuals and their businesses. So welcome, Beth.
Thanks, Mary. That's quite an introduction. Mary and Susan asked me to speak for 10 minutes as the opening act to the main talk. And oh, there on the screen, you'll see my list. Anybody who knows me knows I can't cover any topic in 10 minutes. So I decided to make my top 10 list of the ways that people can avoid paying me more money than they need to. In other words, the things that would avoid the problems I see the most commonly. I think one of the things that's really important to remember, because it's easy to assume otherwise, which is appropriate to the first point, is that really good, well-intentioned people on multiple sides of any event can still run into a problem. It doesn't require malfeasance or cheating or bad intentions. There are just things that are prudent to do. And the first one is to assume that not everybody assumes the same things you do, especially in ongoing arrangements, training, board, facility rental, those sorts of things. Don't assume that what you think is going to happen is what the other person thinks is going to happen. And so if you're not sure, if it hasn't been stated, it's good to cover it. If you're buying a horse, if your vet, your trainer, your mother, your own instincts tell you to stop and think about something, even though it's the quote unquote perfect horse, stop, think, or go find another horse, but don't ignore those signs, no matter who's giving them, and especially if you're giving them to yourself. Number 3, at least 2 people should know everything. And this is especially true around barns and around sports where people can get hurt. If you're the only person who knows something, how an animal needs to be medicated, who to call if you fall off and hit your head, anything, somebody else should know. Teach them, tell them, make sure somebody else can step in. That's a key one. That creates tragedy if it doesn't happen. So it's important. If you are 18 years old or older, have an estate plan. You're an adult. Nobody else can speak for you. Having things land in probate court because you don't have the right documents in place is a mess. And if you're alive and you just need somebody to pay your bills, it's a mess that's going to cost you a lot of money you probably need for something else. It's not that hard to do. Read your insurance policies, all of them. Don't assume what's in them. If you can't understand them, don't feel like there's anything wrong with you. They are the worst written documents on the planet. And a lot of them have big coverage holes in them. So it's important to know what's in your insurance policy and how it matches what happens in your life. One of my favorite money-making statements is, I got the agreement off the internet. Be very careful of pre-written form contracts. They're not written for you. They're written for the least common denominator. They're written probably for the laws of a state you're not sitting in, and a situation that's a little different than yours. So if you want to start with one and customize it, have somebody help you customize it, put your brains together with everybody else involved and make sure everything's covered, fine. But do not just take a form agreement or one that somebody else thinks works well for them. Not a good idea. A small example, right now I'm working on a case where there's the lease of a horse. The lease of the horse is 10 times, the lease fee for 1 year is 10 times the most I've ever paid for a horse in my life to purchase. It's a huge dollar lease. The trainer of the horse owner wrote the lease agreement, and she put nothing in there about what happens if the horse gets hurt, who's responsible, who takes care of it for the rest of the lease. Does the lease end? Is the fee refundable because it's a huge amount? None of that was covered. It was a form contract and it's a mess. If a person won't put something in an agreement that you want covered, your red flags should go up everywhere. If you are a trainer or a farm owner and they won't sign a liability release, they're saying, but if something goes wrong, I will sue you. That's why I don't want to sign this. So just don't take that one lightly. And it's probably not the only time you're going to disagree with them, in my experience. Don't be the banker. If you're selling a horse and somebody says, can I pay you over time? The answer is no. You can't afford this horse. If they can't get a loan from their bank, their investment banker, their father, whatever, they probably also can't pay if the horse colics. And you're going to be the last person that gets paid, especially if something happens to the horse. If it goes lame, if they're disappointed in it. If the down payment is enough for you and the rest is a bonus, okay. But realize it may be all you get. Any professional you hire, and this is one of my pet peeves, and so I gave it a little paragraph. Trainers, veterinarians, lawyers, accountants, any professional you hire in any aspect of your life, but especially where animals are involved because they can't stick up for themselves, should treat you with respect, should give you the time you're paying for. They should answer all of your questions. They should make sure you understand, and they shouldn't make you feel stupid about it. You're paying them to give you the knowledge that they say they've acquired. If they don't, or if you're afraid to raise a question, and this happens really often in training relationships, if you're afraid to raise something that concerns you, go away and find somebody you can talk to. The one that I'm seeing most is the least part of my turf, and I'll be curious to hear what Meghan thinks about this last point. But the dressage world went COVID crazy. And because they couldn't travel around to buy horses, they just bought horses off of videos, off of recommendations, because they were buying them from a friend, wrote huge checks. And I'm not talking amateurs. Some pretty experienced professionals ended up with horses that are unsound, unrideable, unsafe. Know what you're getting. And if you can't suss it all out, stop and go back. The thing that I've seen over time, not just COVID, is that we've gotten way too dependent on imagery. The machines, you can take a picture of anything, bones, soft tissue, hot spots in nuclear scans. That's all great. But I cannot tell you how many times I have heard somebody say, we never really saw him jog straight because he was jumping around. Or, yeah, he held his head a little funny in the pre-purchase exam, but you know, all the x-rays came out okay. And my vet in America said it was okay, but no, he didn't watch a video of the clinical exam. He just looked at the x-rays. Pay attention to clinical exams. That's why you pay a vet to be there. The tech could shoot the x-rays. But I've seen a lot of very expensive horses with conditions where in hindsight, either the owner or the trainer said, yeah, I saw that, but I didn't pay enough attention to it. The corollary to that I've learned over time, and again, Meghan or Lendon, I'd love you to weigh in on this, is somebody other than, especially by the way, with upper level horses, with highly trained horses, somebody other than the rider who trained the horse should ride the horse in front of the vet. And the reason for that is that those are usually very expensive horses. And I used to say, by the way, that only the person who knows the horse should handle the horse in the vet exam, and the buyer should stand there and watch with the vet for liability reasons, because they don't own the horse yet. But horses and people learn to dance together. And a horse that looks sound with the rider that has ridden it for 5 or 8 years may have some compensations that the rider's helping him with, even unconsciously, that blow up as soon as somebody else is training that horse. And I've seen some pretty successful horses turned over to a very capable new rider and fall apart. So and one recently that was one of the COVID crazy horses, where the guy who trained the horse came from Peru, I think, back up to New England to ride the horse after the buyer said, hey, this horse isn't sound. And he could make the horse look sound. There was nothing sound about the horse. The vet was appalled. Pay attention to what's above the legs. That's the other one. I've seen some real problems with necks that weren't checked out enough. Back issues, I think we're getting pretty good at, but don't discount funny head carriage, stiff necks, that sort of thing. And don't assume people who like you genuinely and are sincerely friendly to you can't sell you a horse that's problematic. Their definition of problematic may not be your definition or your trainer's definition of problematic. In my mind, a horse is somebody that you are hiring and trusting with your life, your safety, and a lot of your money. And I don't know why we don't check them out more thoroughly like we would an employee. Check their references. When I sat at the US Western team, I actually got a fair number of phone calls from people who said, can you verify, I'm looking at this Grand Prix horse and they said he was shortlisted for the 19 whatever team. Couldn't find the horse in the records. It's very easy now with American horses to check the USEF affiliate record, you know, the competition records, check them out, make sure it's legit what they're telling you. Talk to people who know the horse, talk to the farrier. He knows if the horse is a pig to deal with, I'll tell you. But really check the horse out beyond a vet check and your trainer, and find out about his history, especially if he's more than a baby. And if he's a baby, don't think you need to skip the vet check, because you don't. I've seen some pretty sad ones where somebody bought a young horse from the breeder and it threw OCD chips left, right, and in the middle that would have been found, at least the initial ones, on a pre-purchase exam. So that's my top 10 list. And I'm happy to take questions. I know that that's a fairly quick breeze through, but those are the big red flags to me. And those things, I will say, quite frankly, have made me a lot of money. That is really too bad, because they were pretty much all avoidable.
If anyone has any questions, write them quickly in the chat and we'll pass them on to Beth.
Lyndon, while people are typing in the chat or not, have you seen the thing where well-trained horses don't, I mean, there are some famous cases, but really can't cope with a new rider?
Oh, absolutely. I think that's not all that unusual.
No, but it's not all that well discussed, I don't think. And huge money gets paid for these horses on the assumption that they'll go on with person B like they did with person A. And horses have preferences too.
Well, look at probably the most famous one, which was Totalis.
Yeah, absolutely.
You know,
but he's not the only one. And Americans have bought a few of them.
I mean, much lower, much less fancy horses than Totalis for sure.
Yeah, and some fancy horses. They just quietly disappeared when they didn't work out, instead of people trying to show them and having it not work. So you don't hear as much about them. But there have been a couple of Olympic team level horses. Right.
Well, Beth, I think you covered the 10 minutes.
Okay.
I mean, you covered your 10 things, and
I think we do have one question just before we move on. In terms of a horse that's potentially dangerous, which I guess everyone probably has their own definition of what a dangerous horse is, what is the seller's obligation to disclose information?
The seller's obligation, horses are considered a good from a legal point of view, just like a refrigerator or a car or anything else. The seller's obligation is to disclose anything that the buyer can't reasonably discover with the examinations the buyer has the opportunity to conduct. So if the seller knows of something that would have shown up obviously on a vet check and the buyer opted not to do a vet check, that's the buyer's problem. But if the horse was calm, cool, and collected, when the buyers came to try him and the buyer turned out to be somebody who wasn't quite as good a rider as expected, and the horse just happened to have a really good, quiet day, and he's really a rogue, the seller needs to speak up. Ethically as well as legally, by the way. You know, if it's really an unsuitable match, sellers are not under an obligation to sell a horse to anybody they don't think is a good match, and certainly not anybody they don't think is a safe match.
Okay,
Whether they do
great.
it or not, it's another story.
Well, thank you very much. I think
My
that was
pleasure.
a good introduction. Yes, certainly something we could have talked much longer about, but
Yeah.
thank you for giving us a little brief overview. So with that, we would like to move on to our vet, Meghan Wansrath, who is from Tufts. So I'll let her introduce herself. I'll turn it over to you, Meghan.
Great, thank you. Sorry that I wasn't organized to get you a bio. We've been quite busy at the hospital, especially today. But as she said, my name is Meghan. I'm a large animal surgery resident at the university. And, I grew up in southeastern Indiana. I showed paint horses all of my life. I think unlike a lot of people and a lot of my classmates, I didn't know I wanted to be a vet since I was 5 years old. I don't think I really came to that conclusion until I was maybe a junior, senior in high school, and kind of the idea of horses not being in my life anymore after, high school or college was a little bit depressing. And so I knew I was always interested in something medical. I just didn't know the veterinary field would be where I would end up. And that is the path I ended up following. I knew I never wanted to be a general practitioner. I always did want to specialize in something. So I did my undergrad at Texas A&M, and then I came back to Indiana for vet school and went to Purdue. When I finished in 2019, I did a 1-year rotating internship at Pioneer Equine Hospital in California. And then I followed that up with a specialty surgery and sports medicine internship at the University of Florida last year. And then I came to Tufts last July. And so I will be here for the next, 2 and a little bit years still. So that's just a little bit on me. Do I have sharing privileges?
Yes, you do. You should.
So colic is obviously a very, very broad topic, and we could talk all night, but we would definitely go past my bedtime. And it's something I'm really passionate about, particularly from a surgery perspective. And it's obviously one of the most common equine emergencies that we see on a day-to-day, week-to-week, whatever, year-round basis. So basically, I'm going to give us, or you guys, kind of just a broad general coverage of a lot of aspects of equine colic. And then I'll leave, plenty of time at the end for you guys to torture me. Just kidding. But ask all your questions that you might have, and I will do my very best to answer them. Just a general overview of where we're going in this presentation. I'll go over some anatomy, the evaluation of a colic case, a basic colic case, medical versus surgical colics, some prevention and management that we can do, and then was requested that I add in some ulcer discussion here, so we'll throw that in at the end. So Colic just by definition means abdominal pain. And although we almost always assume that means something gastrointestinal, you have to remember that there are other organs in the abdomen as well. So kidneys, the reproductive tract, particularly in mares, you have the spleen in there, you have the pancreas, the liver, and then, you know, things that maybe not even are related to the gastrointestinal tract or the abdomen in general is that there are things called, you know, quote unquote, false colics, where horses may show clinical signs that look like colic, but they're not colic. So that oftentimes happens with horses that have really bad like pleuropneumonia or pleuritis, or horses that are tying up, or even laminitic. They can mimic signs that appear like colic. And sometimes, you know, it's not really determined what's going on before a vet sees it. And, you know, in all of those cases, you know, yes, your horse should be evaluated anyway, but just something to keep in mind. As far as anatomy goes, and I'm sorry, you guys might hear my cat like whipping back and forth. He's at a little bit of a crazy time at this time of night, but the anatomy of the horse genuinely is just one giant design flaw. Like just it's terrible. They need a complete revamp redesign. I don't know how these horses survive in the wild on their own. And I have my job because things go wrong with their GI tract all the time. So this is just an image that I took from Nutrina, and you can follow the, you know, the basic outline of the GI tract here, which is moving from your esophagus into your stomach. The yellow here is the small intestine going into the cecum of the green, which that little arrow is, you know, we're seeing the left side of the horse here, but that's actually on the right side of the horse. And your reddy orange color, that's the large colon, and then the small colon is up here in the lighter orange. So, you know, you can divide it into the small intestine and the large intestine. The small intestine, which is about 75 to 80 feet long. So that's a lot of intestine that honestly, most people can't really visualize or appreciate until you see it open up the abdomen and actually pull out all of the intestines in surgery. It's a lot, but it's composed of the duodenum, which is the first part that goes from the stomach, the jejunum, which is the longest part of the intestine, the small intestine, and then the ileum, which is just a little short segment that connects the small intestine to the cecum. And then the large intestine is composed of the cecum and the colon. The colon has a large and a small component, and then the rectum, which is obviously where we stick our arm to palpate into the abdomen. And here are just some more images anatomy-wise. This is a very nicely laid out large colon tract. So the cecum is shaped like a comma. You can see the base here, follow it around, and this is the apex down here. This is the cecocolic fold, which connects the cecum to the colon. So since the cecum is on the right side of the horse, we start here with the right ventral colon, and then you will hit, this is all laid out in a straight line, but basically it's a double horseshoe in the abdomen. So this is a flexure here at the sternum, and then you go to the left side, and that's your left ventral colon. You hit the pelvic flexure is where it turns around again, and it becomes your right or your left dorsal colon. And then you'll have another flexure here at the diaphragm, and that becomes your right dorsal colon, which then goes into the small colon. And these images are kind of showing you what we visualize or how things look when we have a horse in dorsal recumbency, which is the position they're in for surgery. So you can see the left side of the horse and the right side of the horse and what the organ positions look like, because you have to remember you're upside down. So what you're feeling on rectal, you just have to kind of flip that upside down to what you're actually going to be feeling in the abdomen since they're on their back. And then, you know, I don't think you can talk about anatomy without talking about the parts of the intestine that are prone to impaction. And there usually is a reason that they're prone to impaction. So the stomach can be impacted, and gastric impactions can be difficult to deal with. They can be treated medically or surgically, but basically, you know, the feed material just packs and packs, and you can no longer move anything through, and they're not digesting, and there's no motility. So that's what that black circle here is for. The red circle is showing where the ileum is entering into the cecum. So the ileum here can be impacted, and I'll talk a little bit more about, you know, what specific diet those impactions can be associated with. And then most of the areas of impactions, as you can see with the light gray here, are in the large intestine. So cecal impactions, I think, are probably one of the scariest type of impactions that we have, because the cecum can spontaneously rupture. despite treatment. And even if you take them to surgery, sometimes it doesn't end super well. So nobody really likes to get a cecal impaction and to have to treat them. And so in the hospital, we keep a very, very close eye on the amount of piles of manure horses are passing because we want to identify these cecal impactions very quickly. There's been a lot of literature that has been reported showing that horses that are hospitalized, specifically horses for ophthalmology or for orthopedics, so that have, pain somewhere else in their body that may alter their gastrointestinal motility, are predisposed to cecal impactions. So it's something that we keep an eye on and are very acutely aware of in the hospital so that we can, monitor them and catch them very quickly and treat them successfully rather than waiting until basically the cecum, which can hold like 30 liters of ingesta, fills completely up, and then it's so heavy and at risk of just spontaneously rupturing despite treatment. Here again, you'll see the right dorsal colon going into the small colon. So you can even visualize from this picture, that's a huge change in diameter. And it's the same going from the ventral colon to the pelvic flexure. That's a change in about an average of 50 centimeters in diameter to 8 centimeters in diameter. So when you're squeezing something from a larger area into a smaller area, inherently, you're predisposed to impactions as well there. And then small colon impactions also happen, and those impactions are more often than not associated with horses that also have salmonella. So a lot of horses that come into the hospital that have, the primary veterinarian in the field has already diagnosed them with a small colon impaction, and they come in, those horses go straight to isolation due to the risk of transfer of salmonella. Not all of them have salmonella, but that just, that association has been proven in the literature. Signs of colic. As horse people, I'm sure you guys are aware of what to look for colic. Again, it's a broad scale of aggressiveness of the signs. So more mild things like pawing, just minor inappetence, decreased manure production, which that becomes a little harder if your horse lives with other horses and you don't know who passed what piles or when they were last passed. It's a little easier if your horse is stalled alone or in a paddock alone, and you can see how many piles they've passed. Flank watching, doing the flame in response where they lift up their lip, lying down quietly, I would consider a more mild sign of colic, versus more severely if they're aggressively rolling or thrashing in a sense that you are concerned for the safety of the horse and or yourself. Sometimes horses that are very, very severely painful, you'll see a lot of abrasions on their eyes because that's how painful they are. They're essentially beating themselves up on the ground. A marked increase in heart rate, horses that are down and they're so painful that you can't get them up. Sometimes they're aggressively sweating, their muscles may start trembling or fasciculating. And I'm just going to play this video real quick. This horse isn't actually a colic. This horse had a terrible myositis in the hind end, but this is, and I apologize, it apparently is going to play sideways, but this horse obviously looks very, very uncomfortable. And the thing with this is we were watching this horse in the hospital, and you have to be sure that this horse isn't colicking, right? Because that looks like a colic to me. This horse is down, it's rolling, it's very, you can obviously tell he's uncomfortable. And, we treated this horse or, worked him up as a colic just to kind of make sure there wasn't something else going on at the same time. And that wasn't the case. That wasn't due to his pain, but that's kind of typically what you could see with a more painful colic. And so I put some questions in here too. So should I have my horse seen in the field or should I go to the hospital? And that depends on a lot of different factors. So just a horse, you first notice signs of colic, they're more mild. I think that's great. Just call your veterinarian. If they're able to come out, sure, they can come out, evaluate the horse. Majority of colics do not necessarily need to come into the hospital, and they can be managed in the field with some conservative care. There are kind of some caveats to that or exceptions. If your vet is busy and they're not able to come out, but they're concerned based on what you're telling them, they might say, if you have an option for referral, why don't you go to a hospital? If the horse, let's say you've already given the horse some oral Banamine and it worked for a little bit and now he's uncomfortable again, then your veterinarian might say, okay, he might require some more intensive medical management. It might be better for you just to go to the hospital versus me coming out and evaluating him and then sending him to the hospital anyway. But just remember, not all colics require hospitalization. Your primary veterinarian is someone that can help determine that. And even sometimes if they don't see the horse and they're not able to get out there, they can talk to you on the phone, and based on what you're describing, they may say, you know, potentially he could wait a couple hours for me to get to him, or no, that sounds really bad, I think you should seek emergent care at a hospital. You know, if you come into the hospital, it's unlike, you know, a field call where your vet comes and looks at the horse and then leaves. If you come into the hospital, you're probably staying in the hospital. Since we're a tertiary facility, we don't really have a lot of colics that just come in and you work them up and they leave. They at least stay overnight, and most of them end up in the hospital, you know, for 2 to 5 days, you know, medically, and 5 to 7 days surgically on average. And evaluation. So I'm not sure how many of you have seen a horse worked up for colic, but what could you expect? And there are definitely parts that are similar regardless of if the horse is worked up in the field or if it comes into the hospital. Every horse is going to get a basic physical clinical exam. How is the horse doing? Is it painful? What's its heart rate? What's its respiratory rate? Does it have gut sounds? What do its mucous membranes look like? Sometimes the veterinarians are able to run some stall side blood work in the field, like a PCV and a total protein, which basically just kind of gives you their hydration status. Another value a lot of vets for, if they have the equipment, which is just a little handheld device, will reach for in the field, is something called lactate. So when horses are going through anaerobic metabolism, they will produce more lactate. And just knowing the blood lactate, that's specifically helpful to potentially know how dehydrated they are. You can look at the lactate in the abdominal fluid as well, and that can kind of give you an indication of potentially if things are dying or vasculature is occluded in the abdomen. But that's you're definitely going to get blood work if you come into the hospital, a baseline blood work and potentially full blood work the next day, which will evaluate, you know, all the electrolytes and the kidney values and the liver values in addition to your white blood cells. Every single horse should have a nasogastric tube passed, and I cannot emphasize that enough. So if we go back to our anatomy, horses cannot vomit, and it's because of the angle at which the esophagus enters the stomach and also the musculature at the sphincter. They are not physically able to vomit. If you see what you think is essentially throw up coming through their nose, it's because they're refluxing, and they're refluxing to such a degree that it's spontaneously coming out of their nose. So horses that are obstructed and backing up fluid into their small intestine, if a tube is not passed on them, they can rupture their stomach. And unfortunately, there's nothing we can do for a ruptured stomach. We cannot save that horse. So most people, and definitely I would, consider it malpractice on a colic not to pass a nasogastric tube. If you can only do one thing in the field aside from your physical exam, it should be passing a nasogastric tube. The other really common thing that's done in the field is transrectal palpation. So sticking an arm through their rectum and palpating abnormalities in the abdomen. The caveat to that is the horse's abdomen is obviously very, very large. So on average, we can probably feel about 1/3 of the abdomen. So just because we don't feel anything abnormal doesn't mean there isn't anything abnormal in front of our arm that we can't reach. Most people should be able to reach the back end of the left kidney. The caveat to that is there are giant warm bloods or even thoroughbreds, draft horses, what have you. If you have short arms or you're a short person and your limbs just aren't very long, some people just can't reach that amount. So if you have go-go gadget arms, you can probably reach a lot further than I can. My arm is probably of average length for my size. And then the plus or minuses are, you know, these things probably wouldn't be done in the field, but can be. A lot more vets these days do have access to ultrasound in the field. But if you come into the hospital, the horse will have a full abdominal ultrasound, potentially an abdominocentesis, which is basically sticking a needle or a blunt cannula into the abdomen and taking a fluid sample to see what that looks like. That can also be done in the field. It's just not done as commonly, especially if the horse is going to be referred into the hospital anyway. And then abdominal radiographs and gastroscopy. So those aren't necessarily diagnostics that are done, you know, in the middle of the night on emergency. Those things are scheduled for the next day, usually if we have an indication based on diet or history, clinical signs that the horse might benefit from those diagnostics, but it's not necessarily going to change your immediate treatment plan overnight. So usually those things happen the next day. And here's just a picture of one of my post-operative colics. So this is just an example of the tube has been passed on him. And he has a muzzle here and the tube is tied in with tape. If you don't wear the muzzle, they're going to rub the tube out, even if it is taped in. They don't enjoy, a lot of horses don't enjoy the tube. I don't blame them. We do give them just a little bit of sedation to pass this tube and facilitate the rest of the workup. I have never personally had a nasogastric tube passed, but I have talked to people that have had them passed and they say it is quite painful. So I think it's miraculous that horses ever let us even get anywhere close to passing a tube through their nose into their stomach, because I probably would not let you do that to me without heavy, heavy sedation. And then this is an ultrasound image. So this is what distended small intestine looks like on ultrasound. Small intestinal loops shouldn't be more than 3 to 4 millimeters in diameter. These are very turgid, distended loops of small intestine and fluid filled, but also have some ingesta in them too, which is the mixture of white and gray there. But you know, if you saw this on ultrasound, some people do their workups in different orders. So I usually ultrasound before I rectal, but if I see this on ultrasound, I'm probably going to assume I will palpate small intestine on rectal, which is always, always abnormal. You should not be able to palpate distended small intestine. And so, does your horse need surgery? So I think comforting news is that only about 9 to 10% of colic cases actually require surgery. I think if you did the numbers at Tufts, our percentage would be higher. But again, that's only because we're a tertiary facility and we're seeing the horses that are sicker or that have surgical lesions. And there are plenty of colics that are treated and managed in the field that we don't see. Granted, that number isn't comforting to you if your horse is in the 9 to 10% that needs surgery. And so this is how I explain colics to my students when we're working it up. And not every unit, this isn't actually the way I was taught in school. This is how a clinician was, I heard her explaining it to a student one time and I kind of adopted it because I was like, hey, that's pretty simple. I think that's a good way to explain it and for people to kind of work through diagnoses. So, you know, you have all your colics. And the cause of colic is either, you know, if it's gastrointestinal related, you know, it's usually large intestine or it's small intestine. So usually with your diagnostics, you can put it into one of those categories. And then it's either strangulating or it's non-strangulating. Colics are all an obstruction of some degree, whether they're functional or mechanical. The non-strangulating means the lumen is blocked and fluid and ingesta cannot get through. Strangulation means your vessels and your blood supply is also compromised. And, you know, it's not, there are some cases that, you know, causes that are medical, causes that are surgical, but a lot of things fall in the middle of this Venn diagram where sure, they can be treated medically, but if the horse doesn't respond to medical therapy or we can't control its pain, then those lesions do have to go to surgery to be managed. So examples of things that are managed medically are colitis, gas or spasmodic colic. You know, a lot of those horses that we can't necessarily prove it was a gas colic or a spasmodic colic, but a lot of those horses might resolve with what, you know, we call a therapeutic trailer ride, where they were quite uncomfortable at home and then they took a trailer ride, they hit some bumps, they passed some gas, and they're a lot more comfortable when they get to the clinic. You may notice that the horse's abdomen is a little more distended when you're looking at them. And sometimes I like to ask the owner when they come in, because I don't, you know, sometimes you can look at a horse and they're blown up like a tick and you say that horse is gas distended for sure. But sometimes you don't know the normal contour of the horse and the owner might be able to gauge better for that. And then gastric ulcers, again, are something that are obviously that's not a surgical lesion. Things that definitely need to go to surgery are strangulation. So small intestinal strangulation or a large colon volvulus, which is the equivalent of a large colon or large intestine strangulation. And then enteroliths and fecaliths, so stones or basically giant, hard, firm fecal balls that have compacted and blocked the entire lumen. The horse will not resolve those on its own. It does need our help to remove those. And then again, things that fall in the middle. So most people typically think of impactions or something that can be solved medically. And yes, in the large majority of cases, that is true. However, if horses have massive, massive impactions, as in like, you know, I reach in there and I palpate and I'm like, that is harder than a rock and it is bigger than me. Some of those sure still may resolve medically, but I always warn owners that sometimes they still need surgery to fix them and they can't fix medically. And things that we look at to kind of determine whether they need surgical management, first and foremost, is their pain level. Can we keep them comfortable? So yes, these horses are going to get Banamine. Not all colics that come into the hospital get a scheduled Banamine because we want to know if they're going to get uncomfortable, but horses that have a massive impaction, you already anticipate that's going to be uncomfortable for them and you're going to give them some Banamine. We can also give them sedation and we can give them lidocaine as another analgesic to kind of help support them while they work their way through it. The other thing with impactions is if you think about it, if something is blocking the movement of your ingesta through the intestines, everything in front of that is going to gas up. And gas is very, very painful too. So if they have too much gas, they eventually, again, can rupture. So if they're extremely gassed up, if they're very painful and we can't keep them comfortable, those are the cases that end up needing to be cut if they have the option. Displacements are the same way. There are some simple displacements that can be corrected medically and the horse can, you know, if you hold them off a feed, you give them some fluids and some time, they can be okay. However, again, if they gas up, if you can't keep them comfortable, if a simple displacement then twists and becomes a torsion, those things need to go to surgery. Enteritis, which is inflammation of your small intestine, again, typically a medically managed disease, but sometimes those horses, again, you can't keep them comfortable. They just keep refluxing and refluxing, which is essentially vomiting through the tube. And those horses are taken to surgery occasionally, and you strip their intestines of 3 of the fluid and basically just kind of give them a start over. And then hernias, whether it's in foals or adult horses, and regardless of if it's herniating through the inguinal canal or the umbilicus or incision, not all hernias are strangulating hernias. So some of them can be managed without surgery, but the ones that are cutting off blood supply to the intestine definitely need to go to surgery. So this is an example of a small intestinal strangulating lesion. What you see here is a lipoma. And a lipoma is basically a benign fatty mass. Humans and dogs typically get them under their skin. Horses grow them in the mesentery of their intestine. And it's not actually the lipoma that is kind of the silent killer. It's that the lipomas grow on a stalk on the mesentery. So think of it like kind of like a little paddle ball. And the stalk wraps around the intestines. So you can imagine it's just looping around there and it cuts off the blood supply to that portion of intestine. So this intestine is dark, it's purple, it's congested. I guarantee it's thick, even though I can't palpate it, because if you look at this intestine, although it's not the happiest, it's a little distended and reddened, but that's because kind of secondary inflammation to that. You can see these vessels in the serosa. So that's normal thickness of jejunum versus you can't see anything is here. It almost looks rubbery. So even though I can't feel that, I can guarantee that intestine is very thickened. So that is dead and non-viable. That cannot stay in the abdomen, and you would have to resect that portion of intestine. Here is a large intestinal strangulation. So this is a large colon volvulus. This is something that we see a lot at Tufts. And most of the time, the colon, you know, it may look a little inflamed or edematous and irritated, but this is a really gnarly colon. You can see what normal small intestine looks like here. This is happy, healthy, pink, moving. This is congested, purple. The mesentery has a lot of hemorrhage and edema in it. This I wasn't particularly in this surgery, so I'm not sure if this horse ended up being resected, but this could be a candidate for a large colon resection. The other thing you kind of look at is that when we cut open the pelvic flexure to dump the colon, you look at the thickness of the mucosa. And if it's super thick or the mucosa is not bleeding, those are indications that the intestine may not be viable and should come out. And here is, this I believe was the same case. So this portion of intestine had to come out. Essentially, you take the intestine out and you sew the other ends back together. That's, the simplest way to say it. It's a little more complicated in the surgical procedure, but now that piece is gone and this healthy bowel is sutured to healthy bowel. So just examples of strangulating lesions. The list can be a little exhaustive, but one of the most common strangulating lesions in horses is a strangulating lipoma. And strangulating lipomas are commonly seen in older horses and also Arabians. So an old horse that comes in, I mean, you can think late teens, but horses that are in their 20s and 30s, definitely a strangulating lipoma is always on my differential list until proven otherwise. Even if, the workup in the field wasn't consistent with a small intestinal lesion, I'm still keeping it on my list until he proves that he's not. So essentially the workup, the small intestine motile, it's not distended, he's not refluxing, the abdominal tap is normal, then you can kind of take those things off of their list. But not all horses read the book, so they might not all be classic small intestinal lesions. So you should always have a strangulating lipoma in the back of your mind for older horses. But again, not all of them have something that sinister, but that is something commonly seen in strangulating lesions when we take them to surgery. Another strangulation is something called an epiploic foramen entrapment. And those cases, oftentimes, if we take these horses to surgery and then we ask the owner later, does your horse crib? The answer is yes. So there's been an association proven with cribbing and epiploic foramen entrapment. It's theorized that it changes sucking the air in, changes the pressure within the abdomen and forces the intestine through a very thin, inelastic slit that it cannot come back out of. Intussusceptions is when one piece of the intestine tunnels into the other piece of the intestine. It can happen at different places in the GI tract. It can be associated with anything that might cause an increased motility, and also has been shown to have some association with parasitic infections. Gastrosplenic ligament is basically the intestine getting trapped through a small rent in the ligament between the spleen and the stomach. Volvulus, we see it a lot more commonly in the large colon, but it can happen in the small intestine as well, where it twists on itself. The mesentery, particularly in the jejunum, is very, very long, and it can get holes in it, and then the intestine can slip through that and strangulate itself. And then, as we talked about a little before, hernias can be strangulating as well. These images, so what's really neat is I had the opportunity to work with Dr. Freeman when I was at Florida, and he is by far one of the foremost experts in equine colic surgery in the world. And he also happens to be an incredibly talented artist. So he draws all of the images basically that ends up in his textbooks and papers. So it's really neat. I wish I had that skill, but because he has such great knowledge of anatomy, he can also draw really cool pictures. So this is the left side of the horse. And over here is the normal anatomy. So this is the left kidney, the spleen, this is the pelvic flexure, the ventral colon, the dorsal colon, the stomach, and the liver. And what this is showing is the entrapment, a nephrosplenic entrapment, or you may hear some people call it a left dorsal displacement. So all nephrosplenic entrapments are left dorsal displacements, but not all left dorsal displacements are nephrosplenic entrapments. So this specific entrapment is a nephrosplenic because this colon has now looped up into here in between the space between the kidney and the spleen. So the diagnostics we can use to determine if a horse is a nephrosplenic entrapment are ultrasound and transrectal palpation. So when you palpate, you should be able to feel the back edge of this left kidney. You cannot feel the right kidney, it's too far forward. Even for people with very, very long arms, it's up under the rib cage. And then you should be able to feel the ligament that goes from the kidney to the spleen, and the spleen should be up against the left body wall. when you can feel colon in this space, you know it's entrapped, and then that's a nephrosplenic. But if the nephrosplenic space is clear, but you can feel colon between the body wall and the spleen, that would be a left dorsal displacement. And on ultrasound, you should be able to see the kidney next to the spleen, and the colon should not be up here. What would happen in this case is that you wouldn't be able to see the kidney because the colon will be up here next to the spleen, and the kidney will be out of view. I think I have some videos I can show of that. And so this is the other side of the horse. So the right side, normal anatomy, where you have the cecum in the nice comma shape, and then a ventral colon on the right side, and then the dorsal colon as well. And this is showing a right dorsal displacement where your pelvic flexure that should be sitting on your left side is now displaced cranially, and part of the cecum is now covered with colon. And something else we can look for on ultrasound is you shouldn't necessarily see mesenteric vessels. So on the colon, the mesentery is on the inside of the horse, between the two sides of the colon. When the colon twists or when it's out of place, think of it kind of like a hose that you're flipping around. Those vessels that should be on the inside that you shouldn't be able to see are now against the body wall, and you're able to see them. So even though, you know, depending on who you ask and what you read, displacements are quote unquote true surgical diagnoses to be absolutely confirmed, there are lots of diagnostics that are suggestive of colon displacement. Radiographs are fun. They can be challenging in the equine abdomen because horses are big, right? So we have a huge muscle mass to shoot through, and then they're also filled with a lot of gas. So here it's might be kind of hard to see, but use your imaginoscope. This is a rounded structure here, and that is a stone within the colon that should not be there. And the only way to fix it is to get it out surgically. That's not to say there aren't horses that don't incidentally have stones in their colon and they're not currently causing a problem. What I tell people is that if their horse doesn't have an option to go to surgery to take that out, is that it's a little bit like a ticking time bomb, unfortunately, where it's not going to be a problem until it is a problem. So it may not be a problem when it's in the larger part of the colon, but then when it moves to the small colon, it may completely obstruct the lumen, and that's when the horse is going to colic. And unfortunately, if you don't get that out surgically, it's just going to cause necrosis of the wall that it's right next to, and it will cause the colon to rupture. You don't always, just because you don't see a stone on radiographs does not mean a horse doesn't have a stone. They can roll around freely depending on what part of the colon they're in. And then again, also we're shooting through a lot of mass and tissue here. So it's about an 80% chance that, you know, if they have a stone, you're going to see it on radiographs. The other thing we look for is sand. So this is a lot of sand sitting at the colon. Don't specifically know which part of the colon unless you were to go empty them out. Sand is something that, again, sand impactions happen a lot. And it, again, can cause kind of mild, low-grade chronic colic as well. Can also sometimes cause diarrhea in horses. So not all horses need to go to surgery for this. Most of them can be medically managed with psyllium, which basically binds to the sand and helps excrete it out. But there are impactions that are very, very significant, and they may not just be sand. They may also be like gravel and rocks that those horses do need to be evacuated surgically. And that's another horse that's full of sand. So you can kind of see the outline. It's a little bit like a cloud here, but this is because of the saculations of the colon that the sand follows those contours. And so, that's the only true way to diagnose sand is with radiographs. Yes, you can float their feces and see if sand settles into the bottom of the glove tip, but horses don't always consistently pass sand. So that's not necessarily a good indicator of if you don't have any sand on the float means they don't have sand. The other thing is you can't know how much sand is in there until you take a radiograph. You can also listen to the abdomen underneath their belly on your stethoscope, and it does sound like the ocean, but that's also not very sensitive. Just because you don't hear it doesn't mean it's not there. So the gold standard, if sand is suspected, is to take radiographs. If they need to be treated, you treat them, and then after a certain number of days of treatment, repeat radiographs to see what kind of progress you've made. This is another more picture of Dr. Freeman's images. So this is the large colon volvulus. So this image, again, is the right side of the horse. So you can see the arrows are moving clockwise and the colon is twisting upon itself. And then this image would be as if you're looking at the back of the horse facing its tail. So right side is to the right, left side is to the left. And the colon is twisting around itself, which usually happens right here at the base of the cecum. And these horses are typically incredibly painful. Again, they don't all read the book. So we've had plenty of horses that have come in that have just been, they're mildly uncomfortable, then they might get a little more uncomfortable. And, if it gets tighter, then they might get painful. But a lot of times these horses come in, they're extremely painful. They're hard to keep up. They want to get down. They want to roll. You need to sedate them to even be able to get the full exam done on them. And they absolutely need to go to surgery. So why did my horse colic? So after I finish with my evaluation, I either go up front to talk to the owner, or I call the owner on the phone. And once we get through kind of all of the specifics, a lot of owners want to know, well, why did my horse colic? And unfortunately, that's my answer a lot of times. I think it's a frustrating thing for owners, but it's also a frustrating thing for us as veterinarians where, yes, there are some times where we have an answer, like, your water pipe bust or something happened where your horse didn't get water for 2 days and he had an impaction. Well, that's easily explained. Your horse didn't have a dental exam in many years and he wasn't chewing well, and that's why he had an impaction. Your horse wasn't dewormed and a bunch of parasites built up, and that's why there was an impaction. And again, just because we have associations too. So let's say your horse gets an epiploic foramen entrapment and you're like, well, your horse cribbed, so it's predisposed to that. And my recommendations would be to put a cribbing collar on or try to improve that vice from happening. But again, we can't always, your horse has a simple displacement, or your horse even twists its colon. I don't know. The sun was shining that day. You looked at your horse wrong. He didn't like the grass he ate. Your guess is sometimes as good as mine. And how do I prevent it? Well, if you really want to prevent colic, you don't own a horse. But again, it all kind of comes down to, a lot of the times, is that their intestines are not tacked down well. The large colon is basically, connected at the very front and the back, and otherwise it's free floating. And if anything causes them to gas up or things to move around, they can very easily twist on themselves and also go into the wrong place. So unfortunately, yes, that's frustrating that there aren't always things you can do to improve even the very best managed horses, living the best life where I would like to be a member of that barn and just live in a stall and be taken care of like that, will still colic. Medical treatment, what we can do in the hospital is the horse will probably keep the tube in his nose into his stomach overnight to check for reflux every couple of hours. If they're not refluxing, they're going to get some fluids through the tube, maybe some electrolytes, potentially some mineral oil. Mineral oil is becoming less and less common to give, and a lot of horse owners might expect it to be given. The thing with mineral oil is mineral oil does not break up an impaction. All it does is slide around it. So what I use mineral oil for, if I'm going to use it, is more of a marker of GI transit time. If you're going to break up an impaction, you need a lot of fluids, but I usually rotate between mineral oil, electrolytes, and then Epsom salts, because Epsom salts actually draw the fluid into the intestine to help break up the impaction. Most horses are also going to go on IV fluids. And that's particularly important as well if they're refluxing and the tube is in. We cannot feed them. We cannot let them drink water. So they have to get their maintenance needs met somehow. Hand walking helps increase and stimulate motility. I do have a lot of people that ask about, can my horse roll if he's colicking? And my kind of thought on that is, if your horse is aggressively thrashing and rolling around to the point where he's going to hurt himself, he's going to get cast, no, you should try to not to let him roll. If possible, you should get him up and try to walk him until, you know, your veterinarian can get there. The caveat to that is if it's going to be dangerous to you, obviously don't put yourself in that situation. But, you know, if a horse wants to lie down, maybe wants to roll a little bit, that's not necessarily detrimental to him, and potentially could even help him out if he's displaced. Horses are going to be held off of feed at least overnight when they come in, just to, you know, we don't want to add to the problem. Even if the horse is bright and he looks hungry and he acts like he wants to eat, until he proves that he can stay comfortable and, you know, he's not going to show signs of colic, he will potentially pass feces and, you know, his rectal's normal, he's not refluxing, things like that, then they can be fed, but they have to prove they're okay once they come into the hospital. And then plus or minus pain medication is where I said we don't necessarily put them all on a regimen of Banamine. Most of them don't actually, because we want to know if they get painful, especially if they have a surgical option. All post-op colics get pain medication. In some cases where you know they can fix themselves, but it's going to be uncomfortable, then those horses will also get Banamine. And then, you know, horses that are painful and don't have a surgical option as well. Cilium, if they have a sand impaction, that's passed down the nasogastric tube. And then ice boots, that's something that, you know, that's typically more of a, again, I'm a surgery resident, so I try not to deal with the super medicine-y cases, but horses that are very sick, like enteritis, and they have fevers and they're endotoxic and potentially septic, we want to try to prevent laminitis. So those horses might get stuck in ice boots. And the surgical options, which is much more fun for me to talk about. So this is the colic OR at the University of Florida, and this is the colic OR at Tufts, and this is the horse we actually cut this morning. And so you'll see some differences. One is with the table. So you'll see with this table, these horses just have their legs, you know, normally behind them, and there's padding there to support them. Our table doesn't have that, so their legs are hoisted up in the air. Which means where you see the colon is coming out the back of the legs here to be emptied, we have to take the colon off to the left side. So just differences in positioning on the table. Colics are done under general anesthesia, and I put the asterisk there because there are certain things that can be done standing. And I'll say that standing colic surgery is not fun for anyone. It's much more difficult to do. You cannot get a full abdominal explore. So, you know, when horses need colic surgery, we don't recommend standing colic surgery. Like, they need to go under anesthesia on their back for a full abdominal explore. There are just certain exceptions for things that can be done standing and have been described standing. One of them is a small colon impaction. The other one is when you get that colon flipped again between the spleen and the kidney. If that happens frequently, there's a procedure you can do called a nephrosplenic space ablation, where you can actually tack the kidney to the spleen and close that space so the colon doesn't have anything to go into. And if in certain cases, those horses, their colon is very, very empty, they haven't been fed for days, but they're still persistently displaced, you can do a procedure where the incision's big enough for your hand and you put it in there to kind of plop the intestine out of the way, and then you can close and normally. So it's not something that, don't ask for a standing surgery, you know, in cases that we think are good candidates for it and we don't think need full abdominal explores, you know, people will offer it sometimes, but again, you cannot get a full abdominal explore. You cannot do all of the procedures you need to do standing, you know, like it's hard. Be very, very hard to empty the colon, to untwist the colon. You definitely wouldn't be able to do standing. And then horses that need parts resected, that's not something you'd want to do standing either. So they're on their back and you basically make a midline incision into their abdomen. You correct the lesion, whatever it is. You deem whether the bowel is viable. So is it healthy? Is it alive? Is it going to function post-operatively? If the answer is no, or I don't think so, then you will probably resect the intestine. That can happen with small intestine or large intestine. And sometimes something we do in surgery is owners may be game to take their horse to surgery if, you know, it's going to be a simple fix and we think they'll do really well post-operatively. Sometimes owners do not want to deal with a resection. So we we'll get into surgery and we'll open them, and then we'll call the owner and say, listen, it's worse than we thought, or it's not as bad as we thought, or yes, we do need to do a resection. Do you want to proceed? Do you not want to proceed? So we can have those discussions intraoperatively if our prognosis changes, or if we know the owner does not want to proceed with a resection. And then post-operatively, they're on broad spectrum antibiotics, at least for a couple of days. And then we recheck their blood work. And if it looks okay, they come off. They're on anti-inflammatories, which is almost always Banamine for, 7 to 10 days. The only way they wouldn't get Banamine is if creatinine, which is a kidney value, is high. Anti-inflammatory, non-steroidal anti-inflammatories can be nephrotoxic, so we don't want to damage the kidneys if they're already not happy. In that case, it's unfortunate because we don't have a lot of great pain management option in horses aside from NSAIDs. Small animal is much luckier in that sense, and then I think humans even more so than small animals, but we can give sedative analgesics for them to help with pain, but usually if you rehydrate them and their kidneys are happy, you can put them back on Banamine. And then post-operative quote unquote medical treatment, if the horse becomes painful or has a high heart rate, for one of the first things we do is always pass the tube to check the stomach, make sure they're not refluxing. Some horses will reflux post-operatively due to ileus, which is basically that their intestines aren't moving, potentially because they were irritated with the manipulation in surgery, sometimes due to lingering pain. Sometimes if you do a resection, even if your technique was impeccable, sometimes the anastomosis site isn't functional. And so sometimes horses have to keep tubes in for a couple of days after surgery, and you can't feed them or let them drink. So they need to stay on IV fluids. So basically their post-op care depends on how well they do. Sometimes it can be very basic and simplistic, and you can have them off of fluids and antibiotics very soon and not have a tube in them, and you can start refeeding them, within 18-ish hours, offer them water after surgery and such. But if they need a tube in, then that's a different story. What can we do for management and or prevention? So these are kind of things that we include in a lot of our colic discharges. Again, some of them probably you guys already know and are aware of. One of is which to avoid rapid feeding changes. So you don't just say, today I feed my horse Timothy grass hay, and tomorrow he's going on a complete pelleted diet with no hay. That changes the microbial population of the intestines, which oftentimes leads to gas production. Like what we mentioned before, when there's a lot of gas, the intestines can float in places they're not supposed to be. So generally a recommendation of kind of a gradual changeover of about the course of a week for feeding changes. Always ensure they have access to fresh water. Sometimes in the winter or, even in the summers, horses individually vary. They may not be drinking well. Always make sure they have access to plain fresh water. But in addition, you can offer them a bucket of, we call it sweet tea, which is basically just water mixed in with a little bit of a handful of sweet feed or a little bit of molasses. You can add Gatorade to a bucket. You can add electrolytes. And then adding a salt or mineral block or sprinkling salt on their feed can also encourage them to drink more water. Because unfortunately, unlike us, horses are not social drinkers. Their thirst is driven by a physiologic need. So it's not that it hits dinner time and you say, hey, I should have a glass of water or a glass of milk or whatever, with my dinner, or I haven't drank anything in a while, I should probably drink something. Or, even if you're not thirsty, if the drink is there, you still drink it, or just because you want it. That's not the case for horses. And, that's proven by if you are supplying them with their maintenance need for fluids, mostly usually through IV fluids, they will not drink because there's no drive to drink. And once you discontinue those fluids, then they will drink. And they might not drink right away because, again, you've just given them all the fluids they need. But after they've been off the fluids for, a half a day, then they start eating more, then they start drinking more. Reducing exposure to sand. So again, still important in the Northeast. Feeding them in hay feeders and nets, and then putting a rubber mat underneath to catch anything that falls. That way they're not eating out of the dirt where they could pick up the sand. Sand Clear is also a preventative supplement that you can give. I believe the recommendations are for 1 week every month. You give them this supplement and it contains psyllium. It helps prevent the accumulation of sand. And then diet. So coastal Bermuda hay was a big problem in Florida, and it is definitely associated with ileal impactions. And I think it's a lot most of the time because it's cheap and available in Florida that a lot of people feed it. But consistently you see horses that come in with ileal impactions, so it's not recommended to feed. Round bales have also been associated with an increased incidence of impactions. Same with parasites, so strategic deworming. The equine community and the veterinary community has kind of moved away from just cycles of deworming, and now the recommendation is to do fecal egg counts in the spring and the fall, and then deworm if you need to based on those results. All horses should at least be dewormed once a year, usually in the winter with a product that contains praziquantel, because that gets the tapeworms, which would not show up on your fecal egg count. And then routine dental examinations are very, very important. So having a sedated full oral exam, plus or minus floating the teeth, whether or not they need to. I mean, most horses do need their teeth floated at least once a year to knock down those points. Sometimes horses have bad teeth and they need floated, every 6 months or so, but making sure that their mouths are comfortable, they don't have sharp points, and they're able to chew their food appropriately does cut down on the risk of impactions. And then our bonus is gastric ulcers. So full disclosure, the medicine department usually handles a lot of the ulcer cases, but sometimes we do end up with them on surgery, but we all have the same kind of recommendations. So anatomy of the stomach, there are two portions. There's a non-glandular or a squamous portion, and then there's a glandular portion. So equine gastric ulcer syndrome stands for the squamous findings, and then equine gastric glandular ulcer syndrome is the glandular portion. Clinical signs can vary. We get horses that come in on emergency that might be perceived to be acutely colicky, that, the only thing you find wrong with them is the next day scope them and see that they have ulcers. But oftentimes gastric ulcers are a little more mild, as in the horse, eats a little bit and then gets a little crampy or lays down and doesn't want to keep eating. They might, act a little quote unquote girthy. They might have behavioral changes, things like that. So it's a wide spectrum of how horses react. And there's, you can't say that because the horse has clinical signs for it, that it has really bad ulcers, because there are horses that, people think are acting ulcery and we scope them and they don't have ulcers. There are horses that are showing very, very mild signs and we scope them and their stomachs are trash. And you just wonder, how are they not being more aggressively uncomfortable with this? So you can't always correlate those two. And then the other thing to keep in mind is that glandular ulcers typically take longer to heal. And gastroscopy, which is us putting a flexible camera down their nose, so it follows the same path the nasogastric tube would, goes down their nose, down their esophagus, into their stomach to look at it. And that's the only way to definitively diagnose gastric ulcers. And it's also a way to evaluate how they have responded to treatment. Most people will have you hold your horse off of feed for 12 to 24 hours before. We do need the stomach to be empty because otherwise we can't evaluate it. Most people won't really worry about water. Sometimes if they're in hospital, people might hold them off for a couple of hours so that everything moves out of the stomach. And then this grading system, so this focuses on squamous ulcers, and it was developed by a consensus first by the European College of Internal Medicine people, but it's been standard for several decades. So grade 0 is a normal stomach. Grade 1, the mucosal epithelium is intact, but there's some milding, inflammation, erythema, which is just reddening. Grade 2, you might see some single punctate, small pinpoint ulcers. Grade 3, you either have one large ulcer or some more multifocal coalescing ulcers. And then grade 4, sometimes you'll hear people refer to those as bleeding ulcers. Yes, bleeding is very bad, but they aren't always bleeding just because they're grade 4. It really depends on how extensive and most importantly, how deep the ulcers are. So I really went down a rabbit hole going through our stock of gastroscope images, and it's just most of the horses we scope actually do have some pretty gnarly ulcers. So it was actually really hard for me to find more mild things, but there are definitely some scary stomachs out there. So this is what I would call a normal stomach. So this is the squamous portion or the non-glandular portion, and then this is the glandular portion. So the glandular portion is constantly exposed to acid versus the squamous portion isn't. So if the acid splashes up there, then that can cause damage. And this line that demarcates the squamous from the glandular is called the margo plicatus. It's a fun phrase to say. And oftentimes you will see ulcers and changes along the margo plicatus. And then over here to the right, this is a picture of the pylorus, which is the part of the stomach that is then going into the duodenum, which is the first part of the small intestine. So this is a pretty healthy looking pylorus. It's, pink to pale. It's not red. It's not ulcerated. Again, they're not the grading scale that I talked about. This is what you're grading on the squamous portion, but always evaluate the glandular and the squamous portion. And the pylorus, and even going into the duodenum, that's evaluating the glandular portion. These are some more mild changes here on this stomach. You'll see along the margo plicatus, you have this small little pinpoint ulcer here. You may have a little bit of change right here, but otherwise that doesn't look too bad. Moving over here to the right, this ulcer, you have this single ulcer here that looks a little bit deeper, but again, the rest of the stomach doesn't look too terrible. This is probably about a grade 2 where you have several multifocal smaller ulcerations on the squamous mucosa. And this is a cool image because you can turn yourself around with the camera and you can flip back to see where your camera is actually coming into the stomach. And then here again is probably another grade 2 where we have some small ulcerations here along the margo plicatus. And then it might be a little hard to see on imaging. Again, use your imaginoscope, squint real hard. You can kind of see that there's a little more reddening to this mucosa. The mucosa is intact, but it looks a little bit inflamed in this area. So, that would be consistent with a grade 1. And here we're moving to grade 3. So these are more extensive ulcers. If you think that looks painful, just wait till we get to the next page. But I don't blame horses that are, behaving badly or, quite uncomfortable for this, because it certainly looks uncomfortable. And then this is a different horse, but you can see all of these patchy ulcerations and erosions of the mucosa and then fibrin deposition all around them. And this is another one that's, grade 3. It looks pretty nasty here. This reddening, you can see the difference between the healthy pink mucosa and then this trashed portion here along the margo. And then these would be grade 4. Again, you can't tell per se that these are actively bleeding in the scope images, but look how much of this mucosa is eroded. Like, this just looks terrible, and I wouldn't eat, and I always want to eat, but I wouldn't want to eat if this was what my stomach looked like, because I can only imagine how it feels. And again, here, this just looks like straight cobblestone, where you have so much of the mucosa that's eroded. And here, there's some examples of pyloric lesions. So this is just a little bit inflamed and reddened. It should look more like the picture that I showed you at the beginning, where everything is nice and pink and happy. These are just a little redder than you would like them to be. And here you're actually moving to some ulceration and some disruption of the mucosa. And then when you get over here, like, these are really, really bad. I feel incredibly bad for this horse. I can't imagine how many months this probably took to heal, but these are really, really gnarly. And it's, when you scope these horses and you're like, okay, yep, I definitely have a reason for, why they might have been acting colicky or why they've been behaving badly. Treatment wise, what we do for ulcers. So, we'll make a recommended treatment based on the lesions they have, whether they just have squamous ulcers or whether they have glandular ulcers or whether they have both. And the most important thing to remember is that if you want to successfully treat your gastric ulcers, you have to follow the instructions for the medications, otherwise they won't work like they should. So Gastrogard, which is omeprazole, which is that lovely expensive tube that's like $50 a pop, that treats squamous ulcers. So it's a proton pump inhibitor. It wants to decrease the acid production that portion of the stomach is exposed to. And then sucralfate, which the human trade name would be Carafate. It basically acts as a Band-Aid. It binds to the surface of things. So basically it coats the mucosa of the stomach. So, theoretically coating over those ulcers. So Gastrogard, when you're starting it, takes a couple of days to kind of kick in. Sucralfate is more immediate acting and you give it more often. So in hospital, we give sucralfate every 6 hours, so 4 times a day. That's not super manageable at home for owners. So usually we back it down to either 3 times a day or twice a day when they're at home for sucralfate. 3 times a day is best, but we understand that things aren't always as practical, especially if they're not, you're not the one specifically taking care of them, if they're at a barn or a training center or something like that. But if we want to provide horses some more immediate relief while we're waiting for the Gastrogard to kick in, sucralfate is kind of the go-to choice. And then misoprostol is a prostaglandin E1 analog. So again, that works for your glandular disease. So there you're not decreasing acid production per se, because that portion of the stomach is basically continuously exposed to acid, but you want to upregulate the protective measures, which is the increased mucus production that helps with the lining of the epithelium and then also increasing the blood flow. So what I always tell students when I'm putting horses on a variety of gastroprotectic meds is that the easiest thing to remember is that sucralfate has to be given last because it binds to things. So you don't want other things combined with sucralfate. There are a lot of owners that might try to feed sucralfate in the grain. That will absolutely not work, again, because it binds things. It needs to be given directly into their mouth. They need to be on an empty stomach. And it needs to be at least 30 minutes after the last medication or the previous medication was administered. So, we have this little kind of cheat sheet that we put in the bottom of our discharges for ulcers, which is basically an order of medications. And there are certainly other medications that could potentially be added, but these are the 3 most common. So, you give basically the horse, you get there in the morning, they don't have any feed. If they do have feed, you kind of want to take it away from them for 20 or 30 minutes. You give them their Gastrogard, you wait 30 minutes, you give them the misoprostol, you wait 30 minutes, the sucralfate, you wait another 30 minutes, and you feed them. So you can see that is a little bit painstaking and it takes a lot of time. So that I think, owners have to be really dedicated to doing that at home. But it really is important to follow the order and also the instructions to make sure that they're being adequately treated, because that gives you the best chance at resolving them. A note about misoprostol is that, pregnant women shouldn't handle it, and that you should also wear gloves because it can be absorbed through your skin. Horses that are put on treatments for gastric ulcers because they've been confirmed via scope, usually we treat them for, a month or 28 days and then have them come back and they're rescoped, or their vet scopes them in the field and compares to our images. And then that can determine, do these horses need to be treated longer? Can we taper down? Are their ulcers healed? And, gives you more information from that perspective. So treating gastric ulcers is obviously not inexpensive. Gastrogard in itself is a very expensive medication. So if you think, you get a little bit of a discount if you buy it in bulk with the whole 28 pack, but if you think about, most tubes are about $40 to $50 a tube, and they're getting a full tube every day for 28 days. That's expensive. Insurance, yes, we'll cover it if you have medical insurance and you haven't been treated, for ulcers before. A lot of companies will, but sometimes you have to determine what are you going to use your medical insurance on, type of thing. And then what can you potentially do to prevent ulcers? So lots of horses have ulcers. I'm sure if we just went around and scoped every horse we came across, there are plenty of horses that have some degree of ulceration that are just living with it and they're fine and they're not showing any signs. Thoroughbreds or, race horses, horses that are in high intensity work tend to have a higher incidence of ulcers. Important things to remember are stable feeding schedules are best for horses and their digestion. So the sudden diet changes, are bad not only for the gastric health, but from a colic perspective as well, because they alter the microbial population. Carbohydrate intake, so grains, it's best to decrease those, especially if your horse has been diagnosed with ulcers. So horses that are in a lower to medium level of activity, pretty much most of their caloric needs can be met with forage, and they probably don't need grain. A routine exercise regimen can also help support better digestion. Feeding a small meal prior to exercise. So that goes into play because I mentioned that, the glandular portion of the stomach, that pink portion, is consistently exposed to acid, but the squamous portion isn't. But when you're exercising, you can imagine some of that acid can splash up onto the glandular portion. So providing a little bit of bulk in their stomach before exercise, a half hour to an hour before, can help with that. So, giving them some sort of roughage, like a flake, an eighth of a flake, or, a cup of hay pellets. Purina Outlast Gastric Support is also a supplement that you can feed. Avoiding stressful events, again, if possible. If your horse is a show horse, or he has to travel somewhere, sometimes those are unavoidable circumstances, but especially if your horse is prone to ulcers, you can start them on a preventative dose of Gastrogard, which is a 250-pound dose. A full tube would be a 1,250-pound dose. So if you're just on that preventative dose, a full tube gets you a couple of days. And you start it the day, 1 or 2 days before, you give it the day of, and you give for a couple of days after. The preventative dose of Gastrogard is pretty much equivalent. Ulcergard and Gastrogard are pretty much the same thing. They're just marketed differently. So Ulcergard is the quote unquote preventative. So a quarter tube of Ulcergard is pretty much equivalent to a 250-pound dose of Gastrogard. Sometimes some of them are out of stock in the hospital, but you can use them interchangeably. Some people will also add sucralfate into the mix during these stressful events. That's certainly probably more recommended for horses that definitely have problems with ulcers or have had a history of ulcers. Avoiding large gaps between meals. So if you think about it, horses that are out in the wild grazing, they're continuously having something to digest. They're not going, hours and hours and hours without their next feed meal. So feeding in a slow feed hay net might help keep them occupied, slow them down a little bit. And then, if possible, turning them out on grass, as long as they're not going to get too fat and then they're going to get laminitis type of thing, and allowing them to graze throughout the day is good as well. Avoiding those non-steroidal anti-inflammatories. So that's bute, that's Banamine, that's Equiox, or if you're a Coxib or a Previcox, whatever you want to use. If you need to use those, obviously you need to use them, but they can have negative consequentive effects on the gastric system. So if you need to do them, and again, your horse has a history of gastric ulcers, I would recommend putting them back on gastroprotectants while you do that course of bute or Banamine or whatever you need. And then supplements, again, like adding a quarter cup of corn or flaxseed oil to their feed per day, using gastric outlast support. There are some other supplements you can add as well. So in summary, colic is very, very common. We see it all the time on a daily basis, but it can sometimes be a very complicated disease, has a very wide spectrum of severity, mostly attributed to the fact that the horse is a giant design flaw altogether. Some lesions, unfortunately, the only way to fix them is with surgery. And then again, as we touched on here at the end, gastric ulcers can be a cause of mild recurrent colic, and following protocol to treat them is very important for their resolution. I just want to thank you guys for listening to me babble on for a while. I just had to include a picture of my kitty because isn't he precious? His name is Rasputin, and I forced the Mickey hat on him. But I will happily entertain any questions you guys have as long as you ask them.
Yep, great. So yes, if you have any questions, just please write them in the chat. We will review the chat. I know that's a lot of information, but it's such an important topic. So, go ahead, ask away. And it does look like our first question is U7 gastric aid helpful in ulcer prevention?
One second. So I'll be honest, I'm not really on the up and up with the gastric supplements. So I don't exactly know anything about that particular product. I would have to look it up. Most of the gastric ulcers I deal with actually need, like medication treatment that we prescribe, but based on what owners have told me, I know a lot of people have had luck with the Outlast supplement, but unfortunately, I don't really know much about that particular supplement.
Okay.
My email is, I can include my email, and if you send that to me an email, I could certainly ask my lovely large animal medicine colleagues that may have some experience with it.
Yeah, that would be great. And also, just so everyone knows, I will be sending an email out probably tomorrow just with a recap, and I can definitely include, Megan, I can include your email in that.
I put it in the chat as well.
Okay, perfect.
I will preface that with, sometimes I am not the best at minutely responding to emails, but be patient.
Sounds good. Okay, we have another question. If a horse is turned out prior to being ridden, does that count as a small meal? Because assuming that horse would probably be eating some grass in turnout.
Yeah, I mean, essentially it probably could, there's no way to guarantee exactly how much they've been eating, but most horses are kind of pigs. So if there's grass, they're going to eat it. So if they've been turned out, they probably have bulk in their stomach. If you're concerned about it, you just throw them a tiny bit of hay, but out on grass is probably fine as well. I'll say that I'm, a terrible horse owner, and I probably never fed my horse really a small meal before riding him. So
Yeah, how, like, over the course of, your education and now your residency, like, have you noticed any changes in the field, like any changes in how to treat colic or theories?
yeah, and it's even, I've trained at several different places, and no one practices quite the same. And so, depending on who you learn from or where you train, you get certain habits that you're comfortable with, and you figure out ways that you like to treat things, but then you might move to a place that doesn't do things like that. And, especially being in a resident, sometimes you may not always have control or the authority to necessarily do what you want. You may be a little bit at the will of your senior clinician, but I think I've definitely noticed a change specifically in how I treat my colics. But as far as, again, I don't do any ambulatory work because God bless those people, but that just sounds horrible to me in the freezing cold and the burning hot, summer heat. It just sounds awful. And so bless them for doing that, because I am a temperature weenie and could never do such a thing. I think mineral oil is one of the things that, when I was growing up, and I don't know how we managed never to have a horse colic. We had horses growing up, and I never had a horse colic. And that just seems, now being in the field, how did we get away with that? I have no idea. But just, riding with vets or seeing other people's horses worked up, I think mineral oil used to be like an extreme mainstay. So you say, every horse that colics, it needs mineral oil, or it has an impaction, it should get mineral oil. And then, as you move through schooling and realize, what mineral oil actually does and why it doesn't actually break up impactions, I think, there's a switch between veterinarians not using it to treat, but then also you're kind of sometimes at the mercy of a bit that owners expect it to be given. So sometimes there are veterinarians that are giving it because of that. Again, the other main thing I think is what I talked about with the deworming, is that deworming used to just be, people would routinely just deworm every several months, and they would rotate products. And that creates a lot of resistance, which is a big problem, not only in antibiotics, but also in parasite control. So I think moving to the strategic deworming, which is actually doing the fecal egg counts and determining whether or not these horses actually do need to be dewormed, has been a big shift in the industry as well.
Okay, super. Well, I think that's it for tonight. So thank you very, very much for all the information that you shared with us. And we really appreciate it.
Absolutely. Again, guys, feel free to email me. Don't be offended if I don't respond immediately.
All right, sounds good. Thank you very much.
You're
Have a
welcome.
good night.
You too.